Thank you for the opportunity to present my thesis proposal. The title of my study is Decoding Team-Based Care for Hypertension Control in Nigeria using causal mechanisms and predictive approaches. This project centers on improving high blood pressure control in Nigeria by analyzing how a team-based care intervention works and who it benefits most. Today, I will walk through the motivation, aims, study design, and methods of this research. My goal is to demonstrate both the methodological rigor of the approach and its policy relevance for scaling up hypertension control. Hypertension is the leading preventable risk factor for cardiovascular disease worldwide, yet controlling it remains a huge challenge. Globally, billions of adults have hypertension, but in many low and middle income countries, control rates are shockingly low, often well below 20%. In sub-Saharan Africa, fewer than 1 in 10 people with hypertension have their blood pressure under control. Nigeria, as Africa's most populous country, exemplifies this problem. At baseline, only about 13% of Nigerian hypertensive patients in primary care had their blood pressure adequately controlled. This is despite many being on treatment, pointing to gaps in consistent care and medication adherence. These sobering statistics highlight a critical public health gap. Hypertension is common and deadly, but most patients are not achieving control, especially in resource-limited settings. To tackle poor hypertension control, the World Health Organization introduced the HEART's Technical Package, a set of best practices for cardiovascular disease prevention in primary care. Each letter in HEART stands for an intervention component, and notably the T stands for team-based care, promoting a coordinated care team to manage hypertension. Team-based care has proven effective. By sharing tasks and following protocols, it significantly improves blood pressure control compared to doctor-only care. Hypertension Treatment in Nigeria program is a flagship effort that adopted Who's Heart strategies. The initial phase implemented a comprehensive hypertension control program in 60 primary health centers in the Federal Capital Territory. This program was set up as a hybrid effectiveness implementation trial using interrupted time series design, meaning it tracked blood pressure outcomes before and after introducing the intervention. The HTN program's intervention was a multifaceted package grounded in the HEART's recommendations and a successful model from Kaiser Permanente. The key components included patient registration and empanelment. Every hypertensive patient was enrolled in a registry and linked to a care team to ensure continuous follow-up. Standardized treatment protocol with fixed-dose combination therapy. A simple hypertension treatment guideline was used nationwide, starting patients on a single pill containing 2 drugs to improve adherence and simplify care. Team-based care with task sharing. Community health extension workers and nurses took on expanded roles. Under supervision of physicians, these non-physician providers handled routine follow-ups and medication titration. Pharmacists ensured medication dispensing and refills, and community health officers and educators supported patients. Performance feedback and supportive supervision. The program introduced regular monitoring, monthly performance reports, and quarterly supervision visits. Supervisors would visit clinics, review their hypertension outcomes and adherence to the protocol, troubleshoot challenges, and then provide feedback and coaching to the clinic teams. This accountability loop helped maintain high fidelity to the intervention. Drug revolving fund. Midway through implementation, a financing mechanism was launched to keep clinics stocked with affordable blood pressure medications and supplies. The revenue from medication sales was reinvested to prevent stockouts, ensuring that patients could reliably get their prescribed drugs. Now, what about program results? Across more than 21,000 patients and over 142,000 clinic visits, blood pressure control improved from about 22% at baseline to more than 50% by the end of follow-up. Looking ahead, the next phase, Run into 2030 expands to 5 additional states and introduces integrated diabetes care. This creates a timely opportunity for the proposed research to explain how and why the package worked, and to identify where and for whom it will work best during scale-up. With that foundation, I will now state the 2 aims that guide this thesis. First, to quantify the causal pathways through which team-based care improves control, and second, to build prediction tools that target support to the patients and clinics that need it most. Answering these questions is crucial, as Nigeria plans to expand the program nationwide. This study has 2 specific aims that together address both understanding and forecasting the impact of team-based care. Aim 1. Evaluate how team-based care improves hypertension outcomes by examining medication-related pathways and contextual factors as mediators. In other words, we will identify which causal mechanisms are responsible for improved blood pressure control under the intervention. Using advanced causal mediation techniques, we'll quantify how much of the intervention's effect works through these pathways versus directly. We'll also examine if the intervention's effect differs across subgroups. For example, do certain clinics or patients benefit more? Aim 2. Develop and validate predictive models to forecast hypertension control outcomes for individual patients and clinics. Here we shift to the where and who question. Using machine learning on the program's rich data set, we will predict which patients are likely to achieve blood pressure control and which clinics might struggle. The goal is a practical tool to guide resource allocation. For instance, identifying high-risk patients who need extra support or flagging clinics that may need additional training or supplies during scale-up. Together, these aims blend implementation science and data science. Achieving both aims will provide a holistic understanding of the team-based care intervention. To help answer these questions, let's dive into Nigeria Hypertension Program intervention. The program unfolded in 3 phases before and during the intervention. Formative phase. Before launching the intervention, the team conducted formative work. This involved qualitative interviews with patients, health workers, and officials to adapt the HEARTS package to Nigeria's context. They developed training materials, set up data systems, and built local buy-in. Essentially, the formative phase set the stage by tailoring the intervention content to fit the local primary care environment. Control phase. This was a pre-intervention baseline period at the 60 participating clinics. During these 11 months, clinics delivered enhanced usual care for hypertension. They did start using patient registries and underwent a one-time training on measuring blood pressure and basic hypertension management, but the full intervention components were not yet in place. There was no team-based task-sharing model active, no new treatment protocol in use, no regular supervision or feedback cycles, and no special drug supply mechanism during this control phase. Essentially, clinics continued with physician-centered standard care, with better record keeping and some training. This control phase data provides a baseline against which to compare the full intervention. Intervention phase. Over these 3 years, the full multi-level intervention package was rolled out across the same 60 clinics. All the components I described, the standardized treatment protocol with fixed-dose combination medications, team-based care, with task sharing to community health extension workers, supportive supervision, and feedback reports, and later, the drug revolving fund and added patient support like home monitoring were implemented. Notably, supportive supervision visits actually began early and ramped up once the intervention launched, indicating continuous quality improvement efforts. Throughout this phase, data on thousands of patient visits were collected, allowing analysis of trends under the new care model. By structuring the program this way, the study can leverage a before and after comparison in the same facilities. The control phase serves as a comparison period of usual care, and the intervention phase shows outcomes with team-based care in effect. This slide shows a directed acyclic graph. essentially a conceptual model of the hypothesized causal pathways linking the intervention to outcomes. Let me explain the key elements of this model in words. On the left is the team-based care intervention. This is our primary exposure of interest. On the right is the outcome we care about. In this case, improved blood pressure control in hypertensive patients. In between are several mediating factors through which we believe the intervention exerts its effect. Based on prior evidence and the design of the program, we identify critical mediators: medication availability at the clinic, prescribing quality and protocol adherence, patient medication pickup from the clinic pharmacy, patient medication adherence over time. Other care process factors like follow-up visit frequency or patient education could be considered, but the main ones are the medication-related pathways above. We also include various contextual and patient factors that can influence both the implementation and the outcome. These act as confounders or effect modifiers in the model. Facility readiness could affect how well the intervention is delivered and inherently affects outcomes. Staffing levels and training might modify the intervention's strength. Geographic context can capture unmeasured factors like community health-seeking behavior or local health policies. Patient characteristics such as age, sex, comorbidities, and baseline blood pressure. These can influence the likelihood of control and potentially how the intervention works. The DAG structure posits that the team-based care improves outcomes, largely by improving medication management, ensuring patients are prescribed the right medications, have those medications available, pick them up, and adhere to them, which then leads to better blood pressure control. The team-based approach is what drives those improvements in prescribing and adherence processes. At the same time, the DAG acknowledges we must adjust for the confounders in our analysis to isolate the intervention's effect on mediators and outcome. This conceptual model guides our analysis for aim 1. It tells us which variables to include and the hypothesized causal order, from intervention to mediators to outcome. By explicitly mapping this out, we can apply appropriate statistical methods to estimate mediation effects while controlling for the right confounders, as indicated by the DAG. Here, I will briefly walk through the methods we will use to identify the pathways through which team-based care produces better blood pressure control. Causal diagrams. We will construct 2 causal diagrams, one representing the control phase with limited team-based care, and one representing the intervention phase with the full team-based care package. Each diagram will map the hypothesized sequence from the team-based care exposure to medication-related mediators such as drug stock, prescribing quality, and medication pickup, and finally to blood pressure outcomes. We will include patient, clinic, and area-level confounders. Having 2 diagrams allows a phase-specific comparison of both structure and effect sizes. Multi-level structural equation modeling. To partition the total effect of team-based care, we will use multi-level structural equation modeling to estimate indirect effects through each mediator and the direct effect not explained by those mediators. Random intercepts will capture clustering at the clinic level and at the area council level. We will incorporate time trends to distinguish secular changes from intervention effects. We will examine heterogeneity by sex, age, staffing levels, and facility readiness to see for whom and in which context the pathways are strongest. Time-varying multi-level structural equation modeling. We will then allow mediation effects to change over time. This answers whether the impact of team-based care peaks early, for example when training is fresh, or strengthens later as supportive supervision and the drug revolving fund mature. Sensitivity analyses. Finally, we will probe robustness to unmeasured confounding and to alternative ways of defining mediators, such as continuous versus binary measures of stock availability or adherence. We will also explore heterogeneity across area councils with random slopes or stratified models. These steps ensure that our conclusions about how team-based care works are not only statistically sound, but also policy relevant, directly informing which levers to strengthen during national scale-up. To complement the causal pathway analysis, I will now outline how we will predict which patients and which clinics are most at risk, so that support can be targeted proactively. Prediction levels and outcomes. At the patient level, the outcome is blood pressure control at the final observed visit, defined as less than 140 over 90 millimeters of mercury. The goal is to identify individuals who are at risk of remaining uncontrolled so that they can receive intensified follow-up, counseling, and medication support. At the clinic level, the outcome is the facility's control rate, with a program target of at least 50% of active patients controlled. The goal is to flag clinics that are likely to fall below target and to direct supportive supervision and supply actions accordingly. Predictors. For patients, candidate predictors include age, sex, baseline blood pressure, diabetes, and other comorbidities, visit frequency and gaps between visits, medication use, pharmacy refill, and measured adherence. For clinics, predictors include the facility readiness score, urban versus rural location, availability, and start date of the drug revolving fund, medication stockout rates, staffing, baseline control rate, and indicators of implementation fidelity, such as adherence to the treatment protocol and frequency of supportive supervision. Modeling framework. We will compare 3 approaches: gradient-boosted decision trees, random forest, and penalized logistic regression with a least absolute shrinkage penalty. Model selection will prioritize balanced performance and interpretability for program use. Data strategy and handling. We will address class imbalance through stratified sampling and class weighting. We will use nested cross-validation with 5 to 10 folds for stable estimates and hyperparameter tuning. We will also conduct temporal validation, training on earlier cohorts and testing on later cohorts to mimic real-world deployment during scale-up. Evaluation metrics. Primary discrimination will be assessed with the area under the receiver operating characteristic curve with a target of at least 0.8 and with the area under the precision recall curve. We will assess probability reliability using calibration curves and the Hosmer-Lemshow test. To aid interpretation and actionability, we will examine feature importance using Shapley additive values and partial dependence plots. For threshold-based performance, we will report sensitivity, specificity, and the F1 score at decision thresholds aligned with program resources, implementation, and use. The expected outputs are threefold. First, a patient-level risk tool that generates early warning lists for clinicians and community health extension workers to prioritize follow-up. Second, a clinic-level forecasting dashboard for regional program managers to anticipate drops in control and to schedule supportive supervision or supply actions. Third, real-time integration with program data systems so that these decision support tools are updated automatically as new data arrive. Together, these predictive tools convert routine data into timely, actionable guidance, telling us who and where to help. While the mediation analysis tells us how to strengthen the intervention components that drive success. To conclude, here's the 12-month plan for this thesis research and the milestones we expect. Phase 1, setup and data acquisition. We clean and assemble the baseline hypertension treatment in Nigeria dataset for 2020 to 2023, complete descriptive analyses for the first table, and finalize the conceptual directed acyclic graph and protocol after stakeholder review. Phase 2, mediation analysis. We will specify and fit multi-level structural equation models and time-varying multi-level structural equation models. We will conduct sensitivity analyses and subgroup analyses by site and patient type, and interpret the mechanistic pathways with the clinical team. Phase 3, predictive modeling. We will train and validate machine learning models with nested cross-validation. We will test performance on the Federal Capital Territory data and maybe early data from new state sites under the next phase of the program. In parallel, we will build the risk score tool and a monitoring dashboard for implementation. As we close, I will summarize what this project will deliver by October 2026 and how those deliverables translate into policy and practice. 1. Academic publications. We expect 2 peer-reviewed manuscripts. The first will present the multi-level mediation findings, using structural equation modeling to quantify the pathways through which team-based care leads to improved blood pressure control in a low and middle income setting. The second will present the predictive modeling work, offering implementation-focused guidance on how to use patient and clinic-level predictions to target support. Together, these papers contribute both methodological and translational insights to global cardiovascular implementation science. 2. Policy briefs and reports. We will produce concise, actionable briefs for Nigeria's Federal Ministry of Health and the National Primary Healthcare Development Agency, as well as partners. These will include evidence-based recommendations for scale-up and targeted guidance for resource allocation. 3. Implementation strategy. In partnership with the Hypertension Treatment in Nigeria leadership, we hope to help refine the national implementation plan. We will emphasize stronger adherence to team-based care practices and integrate predictive alerts into supervision and routine dashboards so that sites can act early when performance falters. 4. Capacity building. We will train Nigerian analysts and officials in structural equation modeling and machine learning methods. We will transfer code, models, and reproducible workflows to support sustained, data-driven decision-making. 5. Broader impact. By integrating causal inference with machine learning, this work advances implementation science and directly informs the expansion of hypertension treatment in Nigeria version 2 across the country. More broadly, it provides a scalable, evidence-based blueprint for adoption of the HEARTS approach in other low and middle income countries. With these deliverables, we move from describing success to explaining it, and then using that explanation to guide scale up. Thank you for your attention. I welcome your questions and feedback.